everyone. I am so excited to see all of you here today. I am Dr. Robin Lange, and I will be talking with you. Oops, got excited there. I'll be talking with you today about narcissism and narcissistic personality disorder. I'm just trying to get everything set up so I can see. All right, so one thing I want to remind everyone of before we get started is that in our Zoom, we can communicate via the chat, but you actually have to click on the chat link at the bottom of your page, I believe it is, to have that chat appear. And so that way, when they send the code for your live CE credit, you will be able to see it. And if anything arises, feel free to communicate with our staff via chat. Okay, so what we have here today, even just on our first page, is the motivation for me talking about this today. I am not somebody who set out in my career to work with narcissism or narcissistic personality disorder. And yet this Google search that I've kind of embedded on the screen here for you all to view is kind of the state of interest in this topic. It is, though this diagnosis is really not, full narcissistic personality disorder is not as common as we think it is. Discussion and hearing talk about narcissism, I hear about narcissism and narcissistic personality disorder pretty much more than any other personality disorder. And my guess is that some of you are here today because that's the case for you too. So what we're going to be doing today, starting out, we've got 2 hours today to be together and really dig into this topic, kind of try and get our minds around what is this that we're working with when people say, is my partner a narcissist? What exactly are we referring to here and how can we be helpful and effective in our answer? So initially, I really love to get a sense of who I'm speaking with, so that I can tailor my presentation to meet your needs. So I'm going to talk a little bit about myself so you know what my lens is as I approach this topic. Hear from you all. Ideally, I'm going to experiment with some polling here, which is going to be completely anonymous polling to get a sense of who you are, your impressions as we go through the talk. And you'll have the option to participate in this through a link that I will present to you that you can certainly text via your phone if you're joining via your phone, text a response, or there will be an option to kind of open another page and we'll see how that goes. We'll talk then about the history, just kind of a very brief history. We only have 2 hours, could spend 2 weeks talking about the history of this diagnosis and learning a little bit about presently as well. What are the diagnostic criteria and what is the difference between somebody who has narcissistic traits or potentially a full diagnosis of narcissistic personality disorder. We'll look briefly at some of the common assessment measures and treatment options as well. So for those 2 sections, we'll really be doing an overview so that when and if you become interested in working with this population, you have a client referred to you, or you wonder, for yourself, is this something I may need to seek treatment for? Kind of what the options are, what to look for here, and also what the prognosis is for treatment. Finally, I think most importantly, this is a challenging population to work with for many reasons that we'll discuss and can be potentially burnout inducing for clinicians. And so just like any of the work that we do in mental health, it's really important to make sure we take the time to care for ourselves. And in part because of some of the beliefs that drive this particular presentation and what is actually effective in working with folks with this diagnosis, it's even more important, in my opinion, that we really dig into what are we going to do to have compassion for ourselves and make sure that we are engaging in adequate self-care. I'm going to be looking down from time to time, just checking in with my tech people, making sure everything is going okay. And if you all notice anything, feel free to let me know. All right, so a little bit about me. I am from Washington, D.C., officially born within city limits. It's not something everyone can, small area, hard to be born within the city limits. For this reason and others, I have a really deep appreciation for art. And I have featured in this presentation, both just for entertainment value and to illustrate some of our points, some art available from the National Gallery Open Access. And I wanted to include the link here just in case anyone else is interested. There are thousands and thousands and thousands of visual images that are open access to increase all of our access and awareness of these really beautiful parts of our culture. So if anyone's interested, feel free. These slides will be coming to you, I believe, after the talk, but open access. I'm officially now mid-career as a counseling psychologist, and feels like it hasn't been 10 years yet, and yet I'm informed that this is the case. I work the Utah Center for Evidence-Based Treatment. It's an outpatient setting, and I am a lot of our psychologists here are lifespan clinicians. I'm one of those that focuses exclusively on adults. And, counseling psychology, for those of you who aren't familiar, generally, or at least when I was trained, we're focusing mostly on intact personality. And so it may be surprising why, how and why did a counseling psychologist come to be interested in personality disorder, and particularly this one? I would say my first experiences formally working with narcissistic personality disorder were in the DC area, practicum sites for I got a master's degree in counseling first, and got to go to one of the kind of major research hubs in that area and work in their employee assistance program. And I didn't know at the time, I thought I was just going to get kind of basic counseling experience, but my supervisor said, yeah, you're going to be working with some NPD. And so that was really not something I approached intentionally, but found that I got a really great experience there and continued to find my training in this area that I got really early on, just as a coincidence, to be really helpful in my work as I continued my training as a psychologist. I am, in terms of theoretical orientation, I practice right now mostly third wave behavioral treatment interventions, and those are things like ACT and dialectical behavior therapy. I also, my training program was psychodynamic in nature, and so kind of don't have a very strong single lens that I'm going to be approaching this topic from. We're going to look at it kind of from all the angles, looking at what has really been shown to be effective in working with this population, and also trying to get, want to present lots of ways of thinking about this, because we have many participants here today, many people who watch this in the future, and our theoretical orientations, I find, often are like speaking different languages. And so we're going to be talking about some psychodynamic conceptualizations. We're going to talk about some, behavioral or social learning theory ideas about how and why this might develop. And we'll also talk too about just general approaches that you can take, if you are doing even, a supportive counseling session, and you think that this might be coming up for a client, what are some stances in the room that you can actually take to be more effective in working with this person? So I'm going to switch in a moment to a poll. We'll try it out, see how it goes, to learn more about you all and kind of what your training backgrounds are and why you're joining today. And then we'll talk a little bit more about why narcissism and why is this an important topic. Okay, so there should be some options here for you all at the top of the screen. You can go, this is Poll Everywhere. I'm trying it for the first time today. You can go to their website, /Robin Lange 128, and you should have access to this poll. And you can also text to 22333 to join. And then just enter a letter as an option. Oh, and we've got, yay, it's amazing. I am so excited that someone was able to access this. We've got a social worker here, and as you all continue to participate, this is anonymous. We'll see who all is joining us today, and that will really help me to make sure that I'm meeting folks' needs. I'll give it a few minutes as we've got quite a number of folks here with us. I want to give everyone time to answer. I thought about the specialties that might be joining, and it's possible that I didn't capture yours. And if that's the case, thank you for your patience. Feel free to select other there. Okay, so it looks like at this point, we have social work in the lead. Thank you all for joining. We have some mental health counselors that, again, that was my terminal master's. It's fun to see you here. Thank you. Some psychologists. And I will acknowledge, my bias as a psychologist. I'm going to be talking just particularly during our self-care section about ethical self-care. And I'm going to be referencing our American Psychological Association guidelines. And so that's something, I know you all are familiar. Social work has a different set of guidelines here. And my impression is that the principles are pretty similar. So my hope is that you will benefit as well. It looks like I might be cutting off there's so many social workers here that you may not be able to see how many there are. Looks like we've got 48% of our participants today are in social work, 12% students, 12% of you are mental health counselors, we've got 20% psychologists, we've got some folks interested from the community, and someone who identifies from a different specialty area profession that I failed to include. So thank you for your patience. I'm so glad you're all here. Okay. The trick is getting out of the poll, I've realized. So we'll see how that goes. I'm going to lock it. Okay. Pardon me while I rejoin my slideshow. There we go. All right, so I have here a quote from Fox 2021, and this is Daniel Fox, got a lovely book on antisocial, narcissistic, and borderline personality disorders that's really comprehensive and looking at kind of differentials in those areas. And just to get on the same page, since we're kind of all coming from different backgrounds, wanted to make sure we talk about what is personality anyway. And so this is the definition that I'll be working with today. It's an internal psychological construct, which makes it hard to measure, right? Constructs, really hard to measure. Determining how an individual views and makes sense of events, interacts with others, and creates expectations as to how the world functions. So our personality is a pretty important variable for us to pay attention to. As I was kind of alluding to at the beginning, as I'm sure you all know, there are a tremendous number of labels that exist for the variability in the expression of what we would refer to as pathological narcissism. So there are actually more than 50 distinct labels. And so if you're joining this thinking, gee, I know it's a thing and I really want to get a handle on what it is, I can validate that. It is hard to know the terms that people are throwing out there, what we've been trained with, experiences even in our own personal life, so many labels and so much to sort through. And so my hope is that this will help. We're not gonna, solve it all, but hopefully will help. So this is, I wanted to use some case vignettes in this presentation to kind of help illustrate some of the concepts. This is a great piece of art from 1975 called The Angry. And rather than make up hypothetical case examples, but also of course wanting to protect confidentiality, I thought it would be fun to look online and see what we could find. And one thing that I found in my searching online was the comment section of Divorce Magazine, particularly in the section on 16 signs you're married to a narcissist. And I am guessing many of you have seen articles like this, read them maybe. Okay, so I'm going to read just some examples of the terms and the amount, the intensity of emotion that people feel around this diagnosis. So this is all responses back from 2018. The first person says, "You will never cure a narcissist or get them to therapy. They are very covert. They have no desire or motive to change. Our son is married to a covert, aggressive narcissist, and we finally had to go no contact. There's no appeasing these people. They'll dismiss your feelings, deflect, lie, minimize, have toxic amnesia, and they above else will never take responsibility for their behavior. You'll be left with self-doubt, guilt, asking yourself how you can be better." And then Desperate and Exhausted says, 10 years ago, our daughter married a narcissist. He's convinced her that her childhood was awful because her mother screamed and yelled at her all the time and tries to this day to control her. We've absolutely not done that. He's created division between her family, and has kept our grandchildren from the entire side of the family. He verbally attacks my wife. He attacks our parenting and our relationship with our daughter to our face. He now says we're psycho and that he never said any of those things. He would never do that. In fact, that's exactly what he did. Everything he says is someone else is doing. And we actually see that he himself is doing. But our daughter can't see it. And then Anonymous says, "I don't know what to do. I am constantly told I'm a manipulating narcissistic person. I started to believe that until I did some research. I started thinking about everything I was supposed to do. And I realized maybe it's being done to me. I have nobody to talk to, and I'm not sure how much more I can take." So this is just a sample. Really, this response section to the article went on, I think this was published, I would want to say in 2018, and it was updated up to the present. So people really had a lot to say about this. I have another poll for you. I just want to know what words come to mind, word or words, after hearing these posts. And this is going to be, ideally, if everything goes according to plan, a little word cloud. I believe we barred profanity, but if you need to use a little stars and asterisks, you're welcome to do that. Got abuse on there. Yeah. I'm like so excited that this is working. I don't know if you all can see my excitement. Yeah, and so the more that folks are using these words, they're getting bigger. Gaslighting. So there's a lot going on here, a lot of emotion that our audience is experiencing, or at least thinking about. Loneliness, sadness, despair. Yeah. So this is why I believe we're probably here today, trying to get our mind around what is going on in these situations. Maybe even we've been in situations like this. Again, very common for people to be experiencing interactions with folks who may meet criteria for this diagnosis, and really painful. Okay, I'm gonna again have to, it's working so well, except for how to get out of it, There we go. All right, play again. Okay, so to validate you all, there was a study done of clinicians' attitudes towards narcissistic personality disorder. And there is certainly a gap between the presence of this discussion online and in the community and what we're doing in mental health with regard to assessment and evidence-based treatments for this condition. The survey asked 173 psychologists from an online forum how they felt about working with folks with narcissistic personality disorder. And most people felt they are just difficult and challenging. They felt like they just didn't have experience with the population, and also that people were prone to dropping out of treatment, which of course makes it really challenging to get any sort of traction, which leads to burnout, at least for me, when I feel like I'm stuck. One thing that was found to improve the experience of folks with regard to working with this population was reporting that they had some sort of a formal training. And so that is really why I'm doing this today, hoping to help all of you or people that you know are maybe entering therapy, clinicians who are in the room who want to use this with their clients, have a feeling that you can make some progress and do something to move forward with folks when they're presenting with these types of symptoms. So that is really my hope here today. Somebody wrote empathy. A few folks wrote empathy on there. And I really love this quote if you are familiar with Pema Chodron. Compassion is not a relationship between the healer and the wounded. It's a relationship between equals. Only when we know our own darkness well can we be present with the darkness of others. Compassion becomes real when we recognize our shared humanity. And so, yes, there's a lot of pain, a lot of anger, and also how can we retain compassion and try for that non-judgmental stance. And often, just to acknowledge, when we're dealing with burnout, when we're dealing with clients we feel like we cannot help, feelings of judgment make perfect sense. And as you saw in the post on divorcemag.com, this is really often the experience of folks when they feel like they're not able to move somebody forward or in a direction or influence or even be heard by someone who may have some of these traits. But this is the stance I'm striving to take today: compassionate, non-judgmental to the best of my ability. Okay, so this is a really lovely work of art by John William Waterhouse. And this is Echo and Narcissus. And I found, it's like, how am I going to summarize this myth for those of you who are not familiar with it? And I found a really lovely schmoop.com, if you haven't seen it, is really fun for summaries. I'm going to read you their summary of what this says. This story is about. So it's ancient Greek mythology, documented by Ovid, and it was written in 8 Common Era. And what Schmoop says is, Echo falls in love with Narcissus, but Narcissus isn't into it. Echo proceeds to pine over Narcissus until her body withers away and only her voice is left. Meanwhile, Narcissus stops for a drink at the small pond. When he sees his own reflection in the water of the pool, he falls hopelessly in love with himself. Unable to capture his reflection, Narcissus stays by the pond until he starves to death. Pretty straightforward, really. So, of note, this is the only diagnosis that I'm familiar with that has a name associated so strongly with Greek mythology. And it's retained this over all of these different reiterations, reconceptualizations of our diagnostic manual. The name stays, it sticks. And so I just think that's interesting to observe what is our attachment to this storyline. And, before we had a diagnosis, before we had psychology as a profession or mental health fields, we had a lot of moral and religious perspectives on these kinds of symptoms. So we've got hubris, pride, vanity, arrogance, haughtiness. These are prints from the 1500s in Europe. So this is something that people were trying to kind of work through and understand for, since 8 CE and before, probably. So we can feel validated, at least, that we're not the only ones who've struggled. So where did we first hear about this in psychology? We have our early psychoanalysts, Otto Rank in 1911, published pretty much the earliest description of narcissism and labeled it narcissism, connected to self-admiration and vanity. And in 1914, Freud, who many of us are already familiar with, whether we like him or not, published On Narcissism an Introduction. And so this kind of idea, the concept here was that we have these survival instincts and that we're either directing that instinct inwards or outwards towards others. Inward direction is really normative with infants, where they're very self-focused, and that's called primary narcissism. Self-love can be transferred to other people or objects, and that decreases our primary narcissism. So ideally, from Freud's perspective, we're starting out kind of with an inward focus and then expanding to focus outward on others. We then have in the 60s, some very serious debate amongst object relation theorists about what is narcissism. And is it something that is okay to have? Is it just terrible and we've got to get rid of it? A lot like those etchings from the 15th century. And Otto Kernberg was taking more of the spectrum type of a perspective, which was in the 60s. So really cool that he was able to think in that way, which is really common and showing up in our DSM today, that things are not necessarily categorical, but more of a spectrum. We can have a range from normal to pathological narcissism. Kohut, on the other hand, he felt that it was part of normative development, but he really felt that it was more on the pathological side to have these kinds of traits still showing up in adulthood, and that it meant that there's something blocked, something is wrong. And he was the first to mention narcissistic personality disorder formally. The 80s, strangely, were also really a big time for narcissism. So there's this famous book, The Culture of Narcissism. It won the National Book Award in 1980. And it suggested that the cultural conditions in the United States were leading to this increase in individual focus and kind of internal self-focus that was problematic and destroying the culture, which used to be focused more on our family. And he actually also, if any of you are kind of into history, Lange advised Jimmy Carter at Camp David prior to his famous crisis of competence speech, where he said, we've got to choose between, we're in this really pivotal point and we have to choose between doing what is best to help our community and our culture versus doing what is serving individuals. And unfortunately, that was not a well-received speech for Carter, and he went on to lose that election, but that's where he was at. So in 1980, this also formally entered our DSM-3, this diagnosis of narcissistic personality disorder. And there's some, I'm not going to read to you everything that I've written, fortunately, thank goodness. But some very specific judgments that are coming up here, such as DSM-3R, that was 1987. These are dramatic, emotional, and erratic folks, and it's including this cluster B conceptualization. So clusters showed up in 1987, and cluster B is where we find narcissistic personality disorder. Even though we're no longer really using this methodology, this is still a term that I hear regularly, like that person's cluster B. So if you didn't know, that's what they're referring to. In 1981, we have Milan's social learning theory. And Milan wrote that narcissism is caused by these dysfunctional socialization experiences, and that children are internalizing their parents' way of viewing and treating them. So they're taking whatever their parents are seeing about them and saying, oh yes, I'm going to absorb that and express that as my personality. And so Milan thought that parents who were socializing their children to believe they were more special and entitled to special treatment than other children were going to be vulnerable for narcissism. And there's actually some research that suggests, this is from 2016, suggesting that, in terms of parental behaviors, some data to support this theory, that when parents are really focused on forcing the child into the spotlight, talking about the child, yes, their IQ is, they're in Mensa, talking about all the things the child knows and does, and overpraising the performances, that those are risk factors for going on to develop this kind of diagnosis in the future. Warmth, on the other hand, like giving a hug and saying, good job. These are things that are not, at least in this study, not shown to lead to any sort of narcissistic vulnerability. So this is a really interesting series of art that I've used called the Voyage of Life. And it goes all the way through in this very, glorified way, the life of an individual. And so this felt like a really lovely series to follow a little bit throughout the talk, because this is often how folks are perceiving themselves or are presenting themselves to the world. Like there's this glow around them. And what we're going to look at is some prevalence information, diagnostic criteria, and common differentials. So when we are feeling and question enter our mind, is there narcissism here? What else could be going on? Which is important to look at too. So this prevalence data is mostly from the epidemiological, survey on alcohol and related conditions from 2011. So it's a little bit dated, but looking at the breakdown of the percentage of folks who completed this survey, to what extent was narcissism present? So of note, even though we have some more dynamic and fluid ways of thinking about this diagnosis now, obviously this data was using an earlier definition of narcissistic personality disorder, which was categorical and based on the DSM-4. So it's like you have these criteria, you get this diagnosis. So it was a little bit more inclusive than our present system. So important to see here, just in general, cross-culturally, even there's some research from Norway that there's a 0.8 prevalence of narcissistic personality disorder. And in the US, we've got 6.2. So interesting to see a little bit, at least, of cross-cultural research here. For gender, we've got a higher prevalence of males. The age range, this is more often, the set of symptoms is more often reported in younger folks than in older. I'm going to talk more about the race ethnicity variables here. Income, it's a bit skewed, also socioeconomic status, right? Our income range, we're seeing a higher prevalence in lower income folks. And then regionally, interesting for us, it looks like the West, where we are now, 6.2%. So I don't know what to make of the regional data. Would love to hear your thoughts in the questions. For the race ethnicity variables, and also gender even, this is this diagnosis and what you all were writing down, what was being reported in the divorcemag.com comment section. It's pretty clear some of this is gender role bound, some of these presenting problems and symptoms. So men are more likely than women to report interpersonal explosiveness or lack of empathy, which kind of cause more diagnosis in that particular group. So the race and ethnicity variables are really important to look at, I think, and highlighting just the need for more cultural formulations when we're thinking about mental health. And so the author said about this data and how they wanted to interpret this, that the behaviors, beliefs, and attitudes that are kind of causing this diagnostic pattern to present may be adaptive amongst minority subgroups when they're driving to try and overcome these adverse circumstances. And so we'll look more at that as we go on, but really important to observe and keep in mind, a cultural formulation as you're thinking about your client and diagnosis. So these are some media portrayals of folks who might meet criteria for full narcissistic personality disorder. You may notice that these are all rather old series. This is just an evidence of when my kids were born And I stopped watching as much television, unfortunately, but I'm really hoping to get back to it. So you all may have some more current examples, which I'd also love to hear about if you want to put in the chat too. It's fun. Any recommendations for series from me too? I'm always accepting those. Okay. So I'm going to look at another case vignette. This one is taken out of, I believe it's the American Journal of Psychiatry. And I wanted to, oops, dang it. Okay. Wanted to present kind of, this is like the type of question that I'm often getting, the type of diagnosis or presenting variables that I'm often seeing when people are referred here and say, someone told me I had NPD. So just take a moment to read this little vignette. And this is from 2015, and you might notice in the variables, they've got 42-year-old married man. There's no racial ethnic groups, lots of things are missing. So just do your best with this one. And I'm going to ask you, what is your diagnostic impression? What do you think is going on with this guy? And you can use, I said there were more than 50 distinct labels out there. So you can use whatever label that or diagnosis that you're familiar with, whatever language you speak when it comes to your mental health training and history. And here's the poll. We'll see how it's going to be. I tried to, this one didn't work out exactly how I wanted. So I want to give you options, but instead we're going to do another word cloud and see how that looks. So you just write in whatever you think. Yeah, could be bipolar. It's a very common differential, in fact. Yeah, some attachment stuff going on for sure. Could be NPD. Yep. I kind of like the word cloud better, actually. Could be PTSD. That is another common differential. Yep. Definitely some attachment feelings here. Yeah. So there's a lot going on with this gentleman, and we have very brief, limited information. To me, it sounded the most of those TV characters, most like Don Draper going in for therapy. Okay, and we learned that I have to escape to get out of this. All right, and play. Okay, so what are we actually talking about with regard to these symptoms that constitute this diagnosis? So as many of you know, the DSM-5 has two models presented for how we think about personality disorders. And so this is the traditional trait-focused model that I'm showing you here. And you need to have 5 out of 9 of these symptoms present. And so a lot of this, we certainly could say, we could deduce perhaps, or make an assumption that some of this could have been present with the gentleman we were reading about before. So our DSM alternate model is a little or substantially more fluid, more complex. So I'm going to take just a few slides to reorient or orient for the first time a little bit to this model. We need to have, for the DSM-5 alternate model, both impairment in functioning and the traits like were listed in the previous. So it's interesting for the gentleman we were kind of reading his data earlier, how much impairment in functioning would maybe be present for this guy. And if we think about it that way, you can see why there may be more likelihood of including folks in this diagnosis if we're just looking at those pathological traits, and also a little more confusion about like, well, lots of people have these traits. Who is it who meets criteria for this? how much impairment in functioning is needed here. And so we need to have clinical impairment in 2 out of 4 of these areas. I'll let you take a look. And then also there's the criterion B, which is 25 personality traits organized dimensionally. And so there are these 5 dimensions that we're going to look at. And again, this is a lot of data. I prefer not to have so much text in a slide, but there's so much good information I want you to have. So you will get the slides in your email after this presentation and can review. So this is the proposed criteria for narcissistic personality disorder in the alternate DSM-5 model. So you can look at here criterion A. We've got identity variables, self-direction, kind of what is this person's motivation with regard to their goal setting. A lot of you mentioned empathy before, and you can see that's showing up here. So impaired ability to recognize or identify with feelings and needs of others. And then intimacy, which was certainly at least how the gentleman in our summary above was presenting, that he's got potentially kind of superficial relationships here, and that he's just talking about them at least as if they're designed to kind of meet his needs. And then with regard to criterion B, there's a focus kind of on the antagonism area with grandiosity, feelings of entitlement, and they use those terms overt and covert. We'll talk about that a little bit later. And then also attention seeking. So attempts to attract and be the focus of attention. Okay, so I'm going to talk a little bit about grandiose narcissism. I have lost my presenter notes, sadly. I'm going to have to restart here for a second, so thank you for your patience. I can't. No, we'll just go with it. Okay, so for grandiose narcissism, there's this, let me actually back up. So 50 terms here, at least 50 distinct terms. I'm going to present to you on the ones that in terms of like factor analytics, these actually appear to have really important diagnostic information included that differentiate between one type and another with a degree of clinical significance. So you're not going to see all 50 terms listed here, even though they may be ones that you've heard. I'm going to talk about the ones that we're working with the most in our day-to-day work with clients, and then happy to take questions too at the end if you have questions about kind of those other terms that you want to know more about. So grandiose narcissism, this is one where our gentleman above was really in this camp. So on the spectrum of grandiose to kind of introversion. It's a more extroverted presentation. There's not a ton of insight here. And because we have that kind of behavioral lens on, we're looking at also how they are coping with dysregulation. So creating these exaggerated sense of superiority and uniqueness is really important here. This is like the traditional presentation of narcissism that most of us are familiar with, and the ones that I put up from TV were really more in this camp. Vulnerable narcissism, on the other hand, is one where they're coping with dysregulation, kind of with grandiosity still, but more in fantasy. They're not really living this out in their day-to-day life. They're more of a group that will avoid interpersonal relationships rather than seeking them out. And that's because of that sensitivity. The internalizing behaviors here are more predominant. And you all were highlighting attachment. They have more of that fearful or preoccupied style. This is a behavior we deal with a lot at our clinic. There's a lot of non-suicidal self-injury and suicide attempts in the vulnerable narcissism side of things. Though really important to note, like many of our diagnoses and categories that we kind of try to create now, we're finding that things are more of a spectrum. So there's still kind of dispute, though this may be where they're at a state level, like to what extent is vulnerable versus extroverted. Is that more of a trait narcissism or state with regard to how much they're feeling like they can be successful in what they're trying to do? Covert and overt. So this is one that I believe was used in the Divorce Mag comment section. And I hear this a lot. So covert and overt is really about expressed behaviors versus your private feelings and motives. And one thing that's important to think about is that we all have behaviors that are covert and overt. So what I'm thinking about, though I tend to say a lot of what I'm thinking about, as those of you who know me know, I also have the things I'm not saying. They're my private feelings and motives, the needs. Why am I doing what I'm doing? And I do have also my expressed behaviors. I'm here today doing a talk, right? You all can observe that. But my personality structure is not described as being either covert or overt. And this is what empirical data has shown, that there's not really much evidence for this as a distinction between types, and really just more of like a momentary, are we dealing with or learning about these problems when the person describes their thoughts to us, or are we able to see the behaviors in the room? Successful versus unsuccessful, on the other hand, is a little what I was talking about before, alluding to, that this is a subtype that's mediated by how effectively the person with NPD is functioning in the world. So successful means perhaps like the gentleman from the vignette, he's attaining his goals. He's got at least an effective enough interpersonal style to form relationships, and potentially with that exploitive nature, which is what was kind of giving people pause, I think, when you're reading that vignette. Unsuccessful, on the other hand, and you may all be able to think of examples of this, where someone has goals that seem perhaps not as accessible or realistic, and also very like a lot of frustration and stuckness in terms of being able to engage with those goals. And then failure to attain goals is often, this is when you're going to see people coming in for therapy. So one of the reasons that there's not a ton of empirical research or data, though I've like gathered more than I expected I would be able to here for you, compared to other what were formerly cluster B types of diagnoses, there is not much research on this group. And what people say is, oh yeah, well, you know, we don't need to learn about narcissism because these people are never going to come to therapy, right? However, when we see chronic failure to attain the goal, as with the covert presentation, this is someone you may find in your office. Things like social withdrawal, grief, depression, substance use, suicidality. These are things that you're going to be seeing with someone who may have this personality structure. And then, of course, so that's more of the chronic. And then the acute is more of that person who was out there engaging in the world, was able to successfully navigate, and then suddenly something happens. So there was our vignette, the gentleman was there, precipitated, like I think there was maybe divorce in that one, or maybe I'm thinking of something else. But anyway, either way, divorce, demotion or firing from a job, folks who were like super successful, and then, you know, the stock market falls apart. These are the people who we're going to see showing up mostly. Other ones would be someone else told me I needed to come. I'm here because, you know, my girlfriend said that I needed to be here. And I'm back. Okay. So let's talk about differentials and comorbidities. So you mentioned many of these, which is so great when we were doing the little word cloud thing. So I saw PTSD come up on there, definitely depressive symptoms. One that I forgot to add on here that can also be the case. I was on a, treatment team yesterday. Our assessment and testing team was talking about ADHD and how that kind of self-focus can often kind of come across as narcissistic, right? Attentional difficulties can show up that way too. So this is really important like I said, it's such a common Google search. We hear about this all the time. These terms are really thrown around, possibly because there's so many of them, possibly because we don't get enough training, and there's just a lot of emotion driving the production of, it's clickbait in some ways to see the word narcissistic spouse, right? So there's a lot out there, and often this is where folks' minds go, particularly in, non-mental health diagnoses, trained populations of people, right? So if this is not a language that you're familiar with, you don't know about these other types of diagnoses and how narcissism and narcissistic traits could look really similar, then a concern is maybe overdiagnosis. There was a book, Generation Me, I think it was called, that came out like in 2015, that was saying that this generation is more self-absorbed, and that it has to do with the self-esteem movement. And so one thing that's really important to think about there is the kind of measures that they were using, that categorical diagnosis where you're either a narcissist or you're not, and it doesn't matter how much impairment there is, and concerns about whether those measures that they were using were kind of over-inclusive in some ways, and maybe didn't take into account either, like I mentioned earlier, cultural variables, or really other presenting problems that could mimic or raise reporting on a measure like that. There's also some really great talks if you're interested in any of these other conditions. There's some other great didactics and trainings on our website that address, for example, autism spectrum disorder and differentials there. I know that's one that is often asked about. This is a really grainy picture, and I apologize for that, but it's kind of helping us to get a sense of this almost like a Venn diagram where there's symptom overlap. This is looking at other personality diagnoses, and you can see the little blobs on here that look like amoeba are different personality disorders in the alternate model, and where those traits are and how they kind of overlap. So it's really interesting. A lot of this stuff like deceitfulness or manipulativeness or intimacy avoidance. Let's see what else. Irresponsibility. These are things that folks often think about as being part of narcissistic personality disorder. And yet really these two areas, that grandiosity and attention seeking, are the ones that really classify folks over in that diagnosis. So sometimes what people may be feeling or thinking about when they're talking to a friend who they think may have this diagnosis, or you're having a feeling in the room as you're sitting with somebody and thinking, narcissism, sometimes just exploring what other personality variables are kind of highlighted and checking the facts on that can be really helpful. And I already started talking about assessment, but we will continue to do this. So again, the symptoms that are going to be showing up in your office as you're sitting down for an intake or wanting to decide what measures do I really want to administer here. The symptoms that we're going to be finding are things like loneliness, difficulty in social relationships, having reports of other people not being able to meet their needs. So they may be showing up, for example, for couples treatment, having divorce, unemployment, or depression. And so even though, what folks are writing down on a screener is, I'm just not in a marriage that is meeting my needs, this is also a common way that people who may meet criteria for this diagnosis enter treatment. So how do we figure out who is who? As I've been mentioning throughout, really important because many of these assessment measures are older and didn't take into account many of the cultural formulation variables that we really want folks to be thinking about today. I like to talk about the addressing model of assessment. Many of you are probably familiar with this, came out in 2001 from Patricia Hayes. And really, this is just a reminder, a really nice little easy to remember. The DD thing, I'm so impressed she was able to figure this out. This is not my skill set of how to put these kinds of things together, but easy for us to remember. Are we taking into consideration issues related to power and the social structure in a community with regard to age, developmental disabilities, religion, ethnicity, socioeconomic status, sexual orientation, indigenous heritage, national origin, and gender? And this is a lovely book. If you have not had a chance to look at this, I highly recommend it. And I've got a references section at the end where you can find that information. So probably the most commonly used measure for assessment of narcissistic personality disorder is the NPI, the Narcissistic Personality Inventory. And this is one that, though it is really often used, it's usually kind of the first measure that folks find when they're thinking, gee, does this person have narcissism? This is one that's easily accessible. It's 40 paired statements. And for example, statements like, I have a natural talent for influencing people versus I'm not good at that. And so there's 40 of these. And there are these 3 primary dimensions. This is a study of factor analysis from 2011, looking at what are we really actually looking at when we measure this. And so I alluded to some trends around the 2000s about this new generation that's so self-absorbed, and they're meeting criteria for this all the time, this diagnosis now compared to generations prior. Important to note that that's the same thing people were saying in the 80s. Interesting, right? And these authors wanted to see what is actually being measured with this particular assessment measure. And is it actually a maladaptive trait that is showing up here? And so they found that there were 3 factors. There was the leadership authority factor, entitlement or exploitiveness, and the grandiose exhibitionism. And the leadership authority dimension was really often linked with positive outcomes, which kind of makes sense, right? Compared to the other 2. And the other 2 dimensions, in particular, entitlement, was linked to maladaptive outcomes. There's a short form that's validated in 2020, NPI 8. So they kind of narrow this down to 8 questions. So this is still a measure that you can give and can be helpful. Just important to think about what is actually being measured here. And if there are, I think looking at the answers one at a time, seeing, do these look like they're kind of more in that leadership authority range versus the entitlement exploitativeness. And again, the citations for that Ackerman study, if you want to look at that in more depth, are at the end of the presentation. Okay, this is the level of personality functioning scale from 2017. And it includes 80 items. And this really helps us get at how much impairment is present. And so if we're doing, for example, clinical interview, it could be structured or not as structured, depending on your style. And you want to get a sense, it's kind of like our old GAF score, right? Of how much impairment is really happening with this person. And that's so essential to deciding whether we're going to diagnose that full narcissistic personality disorder, or if it's more associated with something more general, or we're just seeing some of those traits, but not really much impairment. This one is really interesting. So this is, and I did not include the citation at the top, but I have the book. So this is Rethinking Narcissism. This is by Dr. Craig Malkin. And it was also on Oprah's Book Club 2.0 in 2015. So this is one that was a New York Times bestseller. And so when we have people thinking about narcissism in our office, or if you all are wanting kind of something that's a little more accessible to read, I think that this is really a good option. One thing I like about, so Dr. Malkin put together another scale with the help of some colleagues called the Narcissism Spectrum Scale. And if you're interested, to see, well, where am I on all of these? Or want to give a brief resource to patients that actually has some research basis and is not, just an online quiz from a, People magazine. So those are fun to do too. This is a link I've included here that you can access a short version. So not the full version that they presented on and researched, but a shorter version that gives you these kind of 3 areas. And this I like because we're looking at, as opposed to the NPI, which is either like, are you a narcissist or you're not? This one is breaking down those that 3-factor structure almost that was found in that study we were discussing on the previous slide. So remembering back to that little schmoop.com myth I was reading you about Narcissus. So Malkin is actually pulling out egoism, which is something like people who really have this lack of comfort feeling special and focusing on the needs of others at the expense of their own needs. That is the level of egoism. And it'll give you a little, graphic. These are just examples of kind of where you fall on that spectrum of egoism. Then there's healthy narcissism, which is like that leadership factor that we were seeing before. These people are empathetic, but they're also like potentially really confident and ambitious, but they can also have those reciprocal relationships. Healthy narcissism. So this thing that we would expect, like good cholesterol versus bad cholesterol is how I'm thinking about it. So we want that to be high. And then extreme narcissism, that's the area that most of us are really well educated about. People are potentially having some of those behaviors that look like manipulation, frequent conflict, and just really high highs, low lows with self-esteem and problematic behavior, and talking a lot about intensity here and getting in the way of being able to live that life they want to live. So their research, which was limited, and obviously they want to validate their own measure, it looks like it explains more variance across domains than the NPI, but of course, given there's not as much research on this, it's a newer measure, 2015, I think was when that, I've got the citations still in the back so we can check. But this is one you can take. Okay, treatment options is where we're going next. So that mirror study we were talking about at the beginning with the 176 psychologists talking about how they felt about treating this condition. They also asked, what do you do when you find yourself treating this condition? What are you actually using with patients? And so we have at least a small N study of what kinds of therapies are offered. And again, that was from 2019. So what Muir found was that psychodynamic psychotherapies, and there's a range in there, of course, or DBT were the 2 most frequently reported methods of treating these patients. The second, there were options and other, so it was psychodynamic, and then it was other. That was number 2. But we don't know what other was, which is a barrier. So folks were doing other things than the options that were offered. And their list was pretty comprehensive. And then DBT was 3rd most frequently used. And so treatment dropout. If we have a comorbidity with anything related to narcissistic personality disorder, whether it kind of meets criteria for that full scale, or it's a little bit less intense and doesn't quite meet the full criteria, treatment dropout is certainly a risk. And so the common factor amongst these therapies that have been shown to be effective, I'll talk a little bit about the stance that we can all take, whether we do DBT or psychodynamic therapy that is shown to be effective with working with these folks, but also just wanting to acknowledge that this is something that's going to slow symptom change potentially and help us feel a little bit more burned out. So important for us to know when this is a comorbidity. So psychodynamic approaches, that was that number 1 most frequently used treatment. The specific, like what psychodynamic approaches are being used, really the most effective ones and most frequently used seem to be focused mostly on transference and countertransference. So they are focused on kind of that relational element between the therapist and the client, and what the client may be kind of projecting, to use that language, onto the therapist, and conversely, what we are maybe projecting or what's being evoked within us when we're in the room. And so even though kind of the conceptualization here is different, we're really looking at the process variables and really attending to the relationship in many ways, even though it's not as overtly mentioned as the intention in the psychotherapy, the psychodynamic approaches that we're talking about here. So specifically, transference-focused psychotherapy, which is from Kernberg, 2004, is shown to be effective in working with folks with narcissistic personality disorder. Of course, as we were talking about earlier, the studies that show treatment outcomes and efficacy are limited by a low number of participants. So both issues with regard to, do these folks meet criteria based on that old, more polythetic criteria set that was really kind of categorical in nature, or are they meeting a kind of higher bar here for NPD? DBT, so I tried to find like the most dramatic, most exciting photos of all of these folks. Thought this was lovely of Marcia. Marcia Linehan, we're on a first name basis with Marcia here at UCBT. She, as many of you know, started out working with this therapy, particularly for suicidal and parasuicidal behaviors, and then later for that diagnosis of borderline personality disorder. But there is a lot of research to suggest that this therapy is effective for many other presenting problems that involve a difficulty with regulating affect. And so, of course, as we looked at those criteria, the more impairment that's present, though the way they're trying to regulate their affect is different, there's certainly challenges associated with affect regulation that come up for folks who have a diagnosis of NPD. So little information if you're not familiar with what a full program NPD or DBT treatment includes. But from my perspective, what makes this therapy really effective with folks who have this type of diagnostic presentation is that DBT specifically focuses on therapy interfering behaviors. And so like in psychodynamic therapy, what they're talking about is that like transference, countertransference. In DBT, we're talking about TIB, therapy interfering behaviors. And some of those for folks who may have this diagnosis that you might see coming up in the room, regardless of what treatment you're doing, are having trouble with acknowledging where things are getting hard for them, not being able to incorporate feedback or new learning when you're presenting it, and then expressing some behaviors associated with entitlement. And these are definitely cues to dysregulation in therapists. And so in DBT, we have, fortunately, a whole team of people who can highlight that to us when we maybe don't realize how reactive we're getting. And then mindful self-compassion. This is a really glamorous picture of Kristen Neff. You may be familiar with MSC, particularly in the differences between self-esteem, which folks were thinking, gee, all that self-esteem we subjected our children to in the past generation is what's causing this flare-up in this diagnosis at present. Self-compassion is not associated with any increased likelihood of diagnosis. And self-compassion, again, it's less contingent on things like success or physical attractiveness or performance. And self-esteem, as I mentioned, does have that higher association with narcissism, whereas self-compassion has no association, at least in preliminary data. So this is one that can be, if we can kind of explain why this would be helpful, this is one that can be really effective in work with folks with narcissistic personality disorder. And then surprisingly, group therapy. So in that MIRROR study, that was one of the treatments that was kind of in the top 5, even though people were saying this is a therapy that, you know, we had someone with this diagnosis, we found out later, joined our group, but they actually really seem to benefit. And this is important to think about. This is Irving Yalom, by the way, the father of group therapy. So that's whose picture is here, representing all of group. yeah, when these folks made their ways into group, it was really beneficial for the client, and the therapists in this survey found that it was effective, but also noted that it's not a treatment that's usually being offered. If you know someone has an NPD diagnosis, that's often kind of a rule out in many group therapies. And so that's just worth thinking about. And you can read more about that too, if you're interested. So as promised, not all of us are doing, full team DBT or, a particular mindful self-compassion treatment manual. And we still want to know, what can we do to be effective with clients in the room? And so some of the therapeutic stance and common factors that exist across therapy strategies would be things like discussing your diagnostic impressions with the client. And this is one I should have given like a little reaction word bubble for you. How do you feel when you think about discussing a diagnosis of narcissistic personality disorder with your clients? A lot of ambivalence about that, I would imagine. At least that's what comes up for me when I think about doing that. However, really being able to orient. So for example, if you have someone on your caseload who has been told they have a diagnosis that doesn't include those variables, and they've been in treatment for years and years, and they're so frustrated and angry about why they're not getting better and nothing's working, sometimes really orienting people to what else could be going on here that might be blocking the ability to progress in these treatments that you're doing, and the hope that comes from talking about, yeah, this thing actually has a name, there's research on what we can do, and you have goals, right? Because that's part of the diagnosis. We have these dreams and goals and things we want to achieve. And this diagnosis, some of the problem behaviors associated with the diagnosis might be blocking you. And so this is something that we can work on together, if you're interested, to help remove some of those variables that might be getting in the way. So talking about it that way, I found to be very effective and helpful to kind of set expectations. So some of those behaviors that you might experience as burnout inducing will be less likely, is what I have found. I was just checking to see if we have any important comments. Through. All right, focusing on those shared goals and our relationship. So across all of those treatment modalities, one of the common factors that's really important is that therapeutic alliance and focus on working alliance. And there's some really great measures out there if you want to get more data other than kind of to confirm or get more data about what your gut is telling you about the alliance. There's the Working Alliance Inventory, I believe is freely available. And it's a really interesting one if you're having the feeling there's something going on in the relationship and you're not hearing about it, which is less likely with this particular presentation, but still could happen. This is one that you can give a client and then talk about, how do we each perceive the alliance to be? And I'm able to then look and see how you're thinking about the relationship, even if it's not something that the client is necessarily verbalizing. So there can be some of that kind of tangential or self-reinforcing speech, which is kind of how I feel after talking for like an hour and a half without hearing anyone else's voice. But for me, it's distressing, whereas for someone with NPD, it might feel really reinforcing. And so that's one of those things, again, that I hear about on teams that feels like, oh, it's burnout inducing. I'm trying to work towards this person's goal, and they keep going off on these tangents about how, the boss is really out to get them and it's really interfering. And so just kind of redirecting back and reminder of kind of what that particular task of the session is and how it's related to that person's goal. Again, DBT is what I'm most frequently using with folks when they have this kind of presentation, and the structured outline of a session where we're focusing on really those most important things first. And we've already made an agreement that we're going to do that. And then once we get to that at the end, we'll have this time where you can tell me all about your boss. That can be really effective, whether you're doing DBT or something else. We've already talked a lot about our non-judgmental stance, even though there's a lot of judgments that come up for me, certainly when I'm feeling like someone is attacking me or questioning my competence. trying to kind of touchstone back to how you're thinking about this client and the kinds of variables that have led to this diagnosis is really helpful. And so even, in counseling psychology, historically, we're not as excited about diagnosis and categorization. And yet there's also this really important function of remembering, okay, this is part of the problem that this person is here to work on. It's not about me, even though it feels so personal right now. Validating emotions when they come up. Again, that's hard when the emotions are directed at you, and yet, with appropriate self-care, consultation, and assessment to help you feel sure that you know what's going on, this becomes a bit easier to be able to acknowledge, even though the way you're talking to me about this emotion that you feel towards me is really hard and maybe damaging my relationship, you can really validate and understand why you would be feeling that, given the thoughts you're having here. Remembering to acknowledge progress when it happens. I think for me, setting my pace according to my conceptualization of the client, just recognizing, sure, yes, this person had, a simple case of depression that never had therapy, thought it was going to be quick, and yet they maybe have this comorbidity of NPD. And so I need to set my expectations in terms of the type of change and the pace of change accordingly, and also help the other person, the client, do the same. Some of the modalities, and again, I am biased to talking about DBT because that's what we do a lot of here, really have that built-in element of the consultation team to help you recognize when you're getting off track or getting polarized and get some validation and support from your team. And some don't have that formally built in. And so we'll talk more about that in the self-care section and what can help you effectively work with clients like this. But just remembering to get, you're not probably going to be getting much validation from the client initially, especially as you build the relationship. And so how can you augment what you're getting from others in your mental health consultation community? Shaping curve. So even though those behaviors we might want, I went on a tangent and come back to it. So even though we might really want them and they really want to be at this goal, they're ready to go, they're stuck. It gets frustrating for them, frustrating for us. And just remembering that, anything that we're learning, we're going to be making these small steps, but we're still going in our value direction. And so really kind of reminding yourself, reminding the client that, yes, we're not where you want to be yet. And also look at this progress that we're making, and we can see how this relates to the goal that you really want to achieve. And even in the presence of lots of things that you're saying and doing in this moment that are hard for me, this behavior is really effective, and I'm going to let you know about it. So that's another important thing. Caring for ourselves. So I had a lovely opportunity to attend the APA convention this year in 2021 and heard a lovely presentation about ethics and self-care. And this is still, I believe, available for you to view. So if you're really vibing on this section of the presentation and want more, that's a whole 2.5 hours about ethics and self-care. And one thing that I really loved about this that I have not included, just for sake of time, is the information about how the pandemic has really impacted us. And I know you're all living it and you're well aware. This is just one of—
Thank you so much. I put you to task today. These are all returns.
Sounds like we might have a audio on here with somebody. But I'm going to keep going. Just making sure we can all still hear me. Great. Okay. So this is a fallen jockey. We never want to be the fallen jockey. And yet some days when I show up to work, I feel like that. I don't know. Again, another survey would be good. Okay. So we have risks associated, and regardless of, the profession that we align with, we're going to hear from our particular professional orientation about what are the risks of working as a mental health provider. So these are studies that are mostly work with psychologists, and yet I imagine that you all have experienced this too, those of you who are not psychologists and or have similar research in your fields. So we've got survey here that people are really frequently. So for 30 years, there's, the most recent one was the Shen Miller. So that was one of our presenters. Administered the same survey that was given 30 years before. And working frequently when we are too distressed to be effective is something that we acknowledge we're doing. 40% of psychologists reporting episodes of emotional exhaustion during the previous year. And this was not during COVID times even. Psychological isolation and disrupted relationships are often just byproducts of burnout and being in an industry where we're really giving a lot and maybe having a hard time giving back to ourselves. And there's some research about burnout and stress with research psychologists versus practicing psychologists. And that's really interesting because the practitioners are reporting higher degrees of stress, but also feeling more attachment and positivity about their work in general. So some vulnerability factors also for burnout are professional isolation, not enough leisure or non-work activities, having unrealistic or rigid expectations for ourselves, focusing on others' needs instead of our own. That one's really important because if you remember back to that Malkin measure, there was that whole egoism thing. So that's something that we tend to see a lot of in folks who are engaging in helping professions. And so really important if we may be kind of more on that echo side than the narcissist side of that spectrum, that this is something that is probably going to be really important for us to be aware of when we're working with someone who has this diagnosis. So that transference, countertransference thing from a psychodynamic perspective is going to be pulling a little harder if we're kind of far on that egoism scale. So this is the APA Ethical Principles for Psychologists and Code of Conduct in 2017. And it's just highlighting, I'm taking a moment to just highlight that self-care is really one of our requirements as psychologists to be able to present and be effective in the work that we're doing. So take a minute, take a look at these. And again, I would like a poll that I didn't include on what barriers or limitations are we seeing when we read this? So for me and a lot of other folks, what's coming up here that's a barrier, and this is also really highlighted in that Shen Miller presentation, is over focus on individual responsibility here. Kind of the concerns that people have about having to like ferret out their colleagues and report them, and that's ethical. And really just hard to enact with any clear explanation here of like, what is self-care? How do I do it? This was one of my frustrations on internship. You need to make sure you're doing self-care and take care of yourself, and no real coaching or explanation of how to do that or what that even looks like. That's a barrier. And of course, again, that cultural variable that's really reflected here from, our predominantly white, predominantly male influenced psychology profession is this individual polarization. And so there are some suggested edits to the ethical self-care section of the ethics manual, and we'll see kind of what happens with that. So in case you wanted to know what is meant by self-care, because I know I did, there's a lovely article or actually a whole book by Baker, 2003, and that's again in the references section, that talks about these three components to self-care. including self-awareness, self-regulation, and balancing. And important to note about balancing, I know a lot of us have those really fun balance boards where we know that it's only for a second or two. So it doesn't say balance, like you have to be balanced all the time, because it just means you're stagnant. We don't want that. And what about specific things we can do, strategies? So this is from Norcross and Vanden Boss in 2018, and a specific list of strategies that have been shown to be effective for mental health professionals at maintaining kind of a self-care portfolio of skills. And so this is, of course, challenging to teach anyone to do, because any of these things is going to look really different depending on variables about our personality, our cultural background, how we identify, and our history. And so there aren't really very many plans out there designed for me specifically. And so that's something that I'm really hopeful that we can work on with our colleagues, maybe making a commitment to take this back to our particular work group or consultation circle and talk about what we're going to do in these areas to really make a commitment and foster that kind of community that is holding ourselves accountable, not only for getting charting done, but for also making sure we're setting boundaries, for example. And so we're approaching the end of our talk. I can't believe the time is flying. And I wanted to leave you, before we transition over to questions, and also talking about some other talks and opportunities coming up at UCEBT, I wanted to give you a chance to participate in a mindful self-compassion activity. This is both an evidence-based treatment that is useful for treating narcissistic personality disorder and really effective for ourselves for self-care. So I'm going to go ahead and lead you all through this. It's going to be, let's say, about 5 minutes. So go ahead and find a comfortable position. If you'd like, you can put a hand over your heart as a reminder to bring not just awareness, but loving awareness to your experience of yourself. And take a few deep, relaxing breaths, noticing how your breath nourishes your body as you inhale and soothes your body as you exhale. Now letting your breath find its own natural rhythm. Continue feeling the sensation of breathing in and breathing out. If you like, allowing yourself to be gently rocked by the rhythm of your breathing. Now, in warming up our awareness, focus your attention on your in-breath, letting yourself savor the sensation of breathing in, noticing how your breath nourishes your body, breath after breath, and then releasing your breath. As you breathe, breathing in something good for yourself, whatever you need. Maybe it's a quality of warmth, kindness, compassion, or love. Just feel it. Or you can use an image. Now shifting your focus to your out-breath. Feeling your body, breathe out, and feeling that sense of ease. Please call to mind someone whom you love, or someone who's struggling and is in need of compassion. Visualize that person clearly in your mind. And begin by directing your out breath to this person, offering the ease of breathing out. If you wish, intentionally sending warmth and kindness, something good, to this person with each out breath. Now letting go of what you and the other person may need, and just focusing on the sensation of breathing compassion in and out, and sending something good. In for me, and out for you. One for me, and one for you. If you wish, you can focus a little bit more on yourself or a little more on the other person. Or you can let it be an equal flow, whatever feels right in this moment. Allowing your breath to flow in and out, like the gentle movement of the ocean. A limitless, boundless flow, flowing in and flowing out. And letting yourself be a part of this limitless, boundless flow. An ocean of compassion. Take a moment to notice your surroundings. And when you're ready, gently open your eyes. Thank you to all of you who participated in that. I hope that if you've experienced self-compassion meditation before, that this is one that you enjoy. And if you're new to it, my hope is that this gets you interested in clicking this link, exploring more about self-compassion, and seeing kind of what flavor of self-care really works for you. It's question time. I'm really excited about question time. And I will show you, I'm not sure how we're going to get to question time here, but I will show you too. I apologize for the small print. This is our citations and recommendations for further reading. So a lot of those, the Baker book I was talking about, Caring for Ourselves, The Therapist's Guide to Personal and Professional Wellbeing, that's on there. A lot of the other references, our Oprah Book Club books and our other more scholarly references are on there as well. Differentials between borderline personality disorder and vulnerable narcissism. That is a fantastic question. So yeah, it is, as you saw on that grainy amoeba graphic, there is a ton of overlap in the symptoms that we think about for narcissism and the symptoms that we think about for borderline personality disorder. And so some of the differential there is really going to be looking at to what it, and by the way, of course, we can have as well. So some of those focus on that really needing to seek out relationships to really bolster the person. And then also just this focus, the self-focus element, and kind of these relationships that may be unstable. Those are all things that we also see in folks who are diagnosed with BPD. So my fallback in these cases is to really do a more formal assessment, either giving one of these measures that we've mentioned before, or a SCID, a formal clinical interview, and really checking out where are these symptom clusters, because you're right, it is so complex to really tease these apart. And you may have factors that are falling in lots of those different bubbles from the graphic we looked at earlier. So I am not able to, at conversation 1 to 10 to somebody, completely tease those two apart. And I feel a lot more confident in my diagnoses when I'm using a measure. if that's something, that you have time to do and interest in doing, it is a lovely option to really just help yourself check the facts on that diagnosis. The good news is with that one, if you're using a treatment like DBT, for example, you're going to be treating kind of the same, using an evidence-based treatment for either of those diagnoses. And so that's another way. If you're not really sure, you're not somebody who has either the interest or training to do more of those assessment measures in person with the client, then you can always look for a modality that is evidence-based to treat both of those overlapping conditions and continue to collect some data. So I hope that's like a non-answer answer. I see Sheila has raised her hand. Sheila D, would you like to ask your question?
Yes, I have a question, and I had to get in the car and make my way to my next appointment. So otherwise I'd have put on my camera, but
no problem.
My question is, in your experience, where in your clinical training do you recommend emphasizing students, graduate student study of personality disorders beyond the, personality disorders 101, which is, at least in psych mental health nursing, we have, they have that, but it's always a matter of time for content. And I find as a psychotherapist that we're stressing teaching therapeutic models, the basic therapeutic models, skills, strategies, and theory. However, 30 years of doing psychotherapy has taught me it's the personality disorders that are, woven into, human beings that also tremendously impact the client's ability to engage in the therapy. And so it just makes me wonder, maybe we should be stressing or teaching more content and more detailed content on personality disorders such as narcissism. And I was wondering about your thoughts on that.
Yeah, absolutely. That's a great question, Sheila. I would be so curious to hear from other people, but I know, like I mentioned, I'm a counseling psychologist. And so that's kind of the rationale for why we're not focusing or weren't in my training formally focusing on personality disorder as much. And so I'm actually not sure for other professions where that is more of a focus, where the training, the formal training is coming from for you, or at what point in your training. For me, Sheila, I did not receive any formal training in my doctoral program around narcissistic personality disorder and treatment. So there was really the 101, like you referred to. And then, the more intensive training was really something I was doing at a practicum site or at one of those clinical training sites where happened to have a trainer or a supervisor who was working with those populations and then kind of gave me the additional material. But I do think, offering that even as an option, if there's advanced course material available, and just kind of talking to folks, even in the 101 class, perhaps about, when you are running into, here's the ideal, you have a single diagnosis, it's depression, and, here's how you can treat that. However, when you're getting stuck, or if you're noticing these kinds of interactions or symptoms coming up, this is kind of what could be going on. And if you want to learn more about it, where you could go. I know that was really my intention with this talk for you all, and then would have been really helpful. And probably we all, I'm sure, can remember some experiences from our training where we didn't necessarily walk the path that our client required, and having kind of that punishing or attacking experience. It's nice. It would be nice to get prepped for that a little bit, and acknowledging that some of that learning, it's like, I was certainly motivated to learn more after experiences like that. But if anyone wants to put in the chat or unmute and share their experience of kind of either when you received training in this, or what you think would be a really great time for trainees to get this information, I would love to hear from you.
Thank you.
Of course. Just looking at who else here. Yeah, not sure. I'm not seeing anyone jumping to answer this, Sheila. So this is definitely, if you would like to shoot me an email, I would be happy to consult with some of our clinical psychologist folks in our center and see, is there a training model? And if there is one available for learning about personality disorder, when do we recommend or find it to be most effective? I'd be happy to do some research and send that to you.
Thank you so much. I
Yeah.
think oftentimes it's a concurrent need. It's individually based too, depending on where students are training and when do they need to know. It's trying to meet all needs at once, which of course is impossible.
Yes. I am really validated to know it's impossible for you too. I haven't figured it out. How to do it.
Thank you.
Of course. Any other, for those of you who are still here, any other questions or comments that you'd like to share? Well, thank you all so much. As I was saying to Sheila, feel free, in the chat, there's the link to the CE quiz. And then of course, also all sorts of opportunities of how you can get in contact with me. If you realize you do have another specific question that you want to ask, this is recorded. So I know that's kind of a barrier for some of us to unmute and talk about our question. It would be for me. So can validate that. If you want to shoot me an email, like I said, my email response time is slow, but I do get back to people. So feel free to shoot me an email. My information is both on our website and also in the chat, if you'd like to email me about that. And then, if you recognize that you have a client who maybe has NPD and you're not somebody who feels like really excited about or has the resources to do an assessment or an evaluation, it's certainly something that both our center and potentially other centers across the country and in Utah can certainly help with. And so if you do have a question even about, where can I go? In addition to UCBT, of course, we're always going to give you other referrals. And particularly, if you're in a state, you're joining us from a state that we are not working in, happy to help you sort through where can I refer my client for further assessment. And also questions, just sometimes there's more consultation needed that folks are interested in knowing, well, how do I rule out, or how is it effective to do couples treatment, for example, for someone with this presentation, and when and how do we work through that? So if you're noticing those questions arise, I'm happy to either, point you in the direction of resources for that, or also do some consultation work, because that's something I love to do. So feel free to reach out at any point in the future should needs arise. And also for those of you who are watching this later and not at this time when I'm presenting, that is an option for you as well. So I would give it 2 years for you to email me about this, just like getting CEs about that. Okay. So a whole 5 minutes of self-care before your next patient. You can go to the bathroom. It's great. And I will hopefully see you all again in CE in the future. Take care.